and it is entitled Breaking the Silence. During this year that I've spent as president of the Baltimore County Medical Association, I've received many calls from physicians in distress. And these colleagues haven't been calling because of frustrations with insurance companies or with trial lawyers or governmental agencies. This was something very different. Several called me for help finding treatment for troubled children. Several came looking for treatment for themselves, for depression or for addictions or for crises of confidence. Some came in referral from hospitals or other physicians because of disruptive behavior or clashes with their colleagues and coworkers. And they came with a variety of emotions, with anger, with sadness, with helplessness, but in addition, nearly everyone sounded at least a little bit ashamed. It was clear they didn't view these as noble wounds, like a torn ACL sustained in a football game or something like that. They found it painful and embarrassing to acknowledge these troubles, and they were only calling now because it was too painful not to call. But my impression was that I'd only heard from colleagues in the greatest pain, and I was certain that many physicians are facing difficulties such as these and are reluctant to tell anyone, let alone a colleague, about their suffering. And this is partly because of the embarrassment associated with asking for personal help, but it's also because we value self-reliance and we really prefer to solve problems ourselves. So our first impulse is to do our own analysis of the problem, and sometimes this involves engaging in efforts to diagnose and even treat ailments in ourselves and our families. And this may not turn out so badly when we're dealing with relatively simple and straightforward medical problems, but it's much more risky when problems are manifested in terms of anxiety or depression or substance use and related signs and symptoms. Now, in some circumstances, it may be very reasonable to try to master emotional distress on our own. A Canadian psychiatrist named Mamta Gautam wrote a book called Iron Doc, Practical Stress Management Tools for Physicians. And she suggests a number of strategies that are from the cognitive behavioral kind of lexicon, a number of approaches by means of which physicians can help themselves deal with stress. And these are things like identifying and labeling the stressor very specifically, recognizing that we have more control than we really think we do, identifying which parts of the stressor we can and can't control, and focusing on what we can control and coping with what we can't. But even these arguably obvious measures are easier to talk about than to do, and often problems require perspectives and solutions that can only be provided by another professional. And in these circumstances, it's very important that we not neglect to get help because we're too busy or embarrassed, or because we fear unnecessarily that seeking treatment will compromise our licensure. This kind of neglect takes a toll not only on us, but on our families and our colleagues, and ultimately on our patients. The most tragic toll, of course, is suicide. And every year, 300 to 400 physicians, the equivalent of 1 or 2 medical school classes, commit suicide. This is a higher rate than you see among other professionals, and women are especially at risk. And there are probably many reasons for this. It's a difficult time in which to practice this wonderful profession of ours because of the pressures of rising costs and increasing demands from all quarters, liability risk, and the disappointment of declining prestige and declining incomes. We tend to be hardworking high achievers who expect ourselves to get it right all the time, and of course we can't. Nobody can. We extend ourselves for the sake of others every day, often forswearing rest and recreation and other recovery-promoting pursuits for the good of our patients, and it's not always appreciated by those for whom we've sacrificed the most. And we're, of course, just as vulnerable as other men and women to major depression, which afflicts 10% of women, 10% of men and 20% of women over the course of their lives. And of course, we're also more knowledgeable than most people are about how to kill ourselves, and that may explain why physicians are perhaps the only demographic group in which completed suicides outnumber non-fatal suicide attempts. Now, this story of physician suicide is told very effectively in a documentary from 2008 called Struggling in Silence. This begins with an account of the death by suicide of a physician named John Hansborough, who was an internationally renowned burn surgeon at UC San Diego. He effectively concealed the pain of depression until he couldn't bear it anymore, and he chose the most tragic of solutions. We're then introduced to Blanca Cervantes, who's a medical student at UC San Diego, to Robert Lemberg, a plastic surgeon in Little Rock, and Alice Flaherty, a neurologist in Boston. Each of these people describes the terrible burden of untreated mood symptoms, the impact of these symptoms on their fellow physicians, on their patients, and on their families. Each of them was avoiding treatment initially because of their difficulty accepting the need for treatment, in part because of the stigma associated with those conditions. But finally, each went on to receive treatment, did very well, and are now telling their stories publicly so that their fellow physicians will know that there's no need to suffer silently. If anybody's interested, this documentary is available from the American Foundation for Suicide Prevention and can be previewed at a website, www.doctorswithdepression.org. Now, the AMA recognizes these kinds of problems and has expanded its code of ethics to address physician health. Now, the code states, and this is partly quote, partly paraphrased, that the medical profession has an obligation to ensure that its members are able to provide safe and effective care. And of course, the ability to provide such care clearly depends substantially on a physician's state of health in general and mental health in particular. So the medical profession has obligations to, number one, promote health and wellness among physicians. Number two, support peers in identifying physicians in need of help. Intervene promptly when the health or wellness of a colleague appears to have become compromised. And finally, to establish physician health programs that provide a supportive environment and to maintain and restore health and wellness. So this is what the AMA is saying is the obligation of all of us. And in Maryland, we're extremely lucky to have the Physician Health Program, which is, as you know, a completely voluntary and confidential program that is under the aegis and umbrella of the Center for Healthy Maryland. This program provides assessment, referrals for treatment, and when appropriate, it provides treatment plan monitoring.